Now I can invite Dr. Joerg Ender. He is from Leipzig Heart Institute, and it is our proud privilege to have him here with us. And he is going to elaborate to each one of us about how to analyze the mitral valve by 2D and 3D. Now I can invite Dr. Ender.
Okay, so first of all, I want to thank Dr. Muralidhar for inviting me to that meeting. And I want to express really my sorrow that I could not join you personally. But what I have seen so far, that was really a fantastic meeting. And it's really very nice that the technical issue is solved and it's excellent quality. That's from my talk, because I'm not able. Can you see my slide?
Yeah. Can you just go to your slideshow? We can see the slide.
Yes, now it is?
Yeah, there you are.
So in the next 20 minutes, I will talk about the assessment of mitral valve repair by 2D and 3D echo. My only disclosure is that we are a reference customer for Philips, so all of the videos you will see are from a Philips ultrasound machine. So if we go through the agenda, it's more or less the same which Maurice Hogan, one of my former fellows, and me have written in the last book of transesophageal echocardiography from Reno about the mitral repair. We will shortly talk about the surgical principles of repair and the intraoperative echocardiographic assessment divided in pre-bypass and post-bypass evaluation. So the surgical aspect is more or less there are two major surgical techniques. One is a technique which respects the valve tissue. That means there's no resection, and it's mainly done with artificial loops. And the other technique is the resect technique, where the tissue of the mitral valve is resected. And both of that methods have always an implantation of a annuloplasty ring, which is seen on the left side, to keep the mitral annulus smaller than it was before. So what should we look pre-evaluation, so pre-bypass? One is to quantify the mitral valve dysfunction, which you have heard in the last talk, and then come to assessment of suitability for repair, and maybe some helpful informations, like also the risk factors for SEN, which was also briefly touched in the previous talk. And all of that echocardiographic examinations have to be seen in the context of the clinical information. So please don't use only the echo to make some judgments. That is really very crucial. And the other thing what I want to point out is that first you do it with the 2D examination without color, and then you add the color and all the other things. And the color examination should confirm the things, the pathology you have seen in 2D. So these are the pictures you need, and Dr. Patil has pointed out very clearly which 2D views are necessary, so the transgastric and the midesophageal. What I want to point out is for the midesophageal views, once you have a really good four-chamber view, the only thing you have to do to come to the different other views midesophageal is to do the rotation. That's it. So you have to have the handle as it is, and then just do a forward rotation, and then you see the different parts. Of course, 3D is very helpful because you can display the mitral valve like the surgeon will see that, of course. So, and here you have these motion of the leaflets. And you can divide the mitral valve pathologies in the primary pathologies, which means that the mitral valve leaflet itself are involved, or secondary, that means that mitral valve leaflets are fine, but the left ventricle is dilated, and that is the secondary. And you can divide that leaflet motions in normal, excessive, or restrictive, again with type 3A, which is structural restriction, which most of your patients you see in India will have that due to rheumatic fever. and then the 3B type due to functional MR. So here's some examples. You see it at 1, normal motion of the leaflets, but you see in 3D very well, and on the right upper here, that cleft of the intermitral leaflet, which is better seen in diastole than in systole. Then you have an excessive motion or a prolapse, and you have a prolapse if the free margin of your leaflet is tending to the left ventricle. If you have a flail, then that free margin tends to the left atrium. Then you have morbus Barlow, where you have a lot of excessive tissue. You see that here in 2D and in 3D, which involves nearly all segments of the mitral valve. And then the type 3A, which I mentioned, you see that is the video which I recorded in the TE workshop 2009 in Bangalore, where you see that funnel-shaped mitral valve due to the fusion of the commissures. That is a restriction in systole as well as in diastole. And then you have the 3B, so the functional type, where you have the restrictive motion and only in systole. You see that here also very nicely in 3D, which involves mainly the posterior mitral and especially the P2 and P3 region. So the probability of mitral repair, of course, is depending on the skill of the surgeon, but also on the type of mitral valve pathology. And you see here the rheumatic disease is a disease which is really very difficult to repair. So a simple P2 prolapse is easy to repair. Rheumatic is a little bit more complicated. It's unlikely. And you see again from the American guidelines here, all the things you have to do to assess the mitral valve severity with Doppler. Please remember that under general anesthesia, all the loading conditions are changed. So that means that your MR severity can be less than it was preoperatively. So please don't change your plan if you are not able to see severe mitral regurgitation under general anesthesia. Just adjust for preload and afterload, and then you will see that. And that effect is more pronounced in secondary MR than in primary MR. And here are the severity of mitral regurgitation in the guidelines. It's still, although from 2013, these guidelines are valid. You see that here in the 2017 American guidelines, it's the same. And they were mentioned also in the previous talk, where you have the PISA for the quantitative measurements and then the semi-qualitative and quantitative measurements as well. So the density of the color signal was also mentioned with a mild, which is faint and parabolic, then more dense with moderate, and dense and triangular in severe mitral regurgitation. Remember, in AFib, as you can see that in that video, the density of the signal can vary between beat to beat because of the different loading conditions. So you have to assess at least 5 beats in AFib. Pulmonary venous inflow was also mentioned. That is a really very easy method to judge between normal, mild, and severe MR. You see that with the reversal in severe MR of your pulmonary venous inflow system. If you use color, you have to correct your machine settings. So that means you have to adjust a proper Nyquist limit, which I would say it's between 50 and 70, and the color gain, not too high, not too low, and the transducer frequency, of course. One thing which was not mentioned yet, but which is really very, very important with all the measurements, you have to look at the timing of the MR chip. Because usually we will look at a video loop which has around between 15 and 30 frame rates. And you have to look if your MR jet is just if it's holosystolic as depicted on the left side, or if it's just late systolic or early systolic. Because if it's not holosystolic, you can overestimate your MR, of course. And you can use 3D, what they explain, just to see exactly where you have your regurgitation jet. And you see that here in these different videos where it's clearly more A2P2 and A3P3, and not so much, you see that here in the A1P1 region. 3D is the same video. So, and what we usually use is the Vignette contractor. But you please have in mind that Vignette contractor in 2D will underestimate your MR because the MR jet is not a circle in most of the patients. It's more ellipsoid. So that means just the measurement of the Vignette contractor in one, normally the long axis view, will underestimate. Because you see that here on the left side, in the mitral commissural, the Vignette contractor is much more pronounced, as you can see it here. Mitral commissural, the Vignette contractor would be this, and the long axis is much smaller. So in the guidelines, it's recommended to use a biplane measurement using the Vignette contractor of the midesophageal mitral commissural and the long axis view, and then take the mean average. And again, you see that during the systolic cycle, the dynamic of the Vignette contractor area and the Vignette contractor width can change. Of course, you can use some tools like these mitral valve assessment tools from Contact, where you have a lot of measurements to assess the mitral valve for mitral valve repair. But there are only some measurements which are really very important in clinical routines. So, and there are two. One is the AP dimension, and one is the intertrigonal distance for determination of the size of the annuloposteri ring, which is implanted. That is also what the cardiac surgeons did with the sizer, which you can see here. And which measurements are really required? So one is the annulus diameter. Usually we use the diameter in mitral commissural and in the long axis, and the length of the leaflets. Then the C-sep distance, which is the distance from the coaptation, see it in the left lower, to the septum. And then the diameter of the left ventricle in diastole and the length of left ventricle. And of course the tenting height and the tenting area, which was mentioned before in the previous talk, where usually the long axis view is used to have that. And then one of my research topics, of course, the distance to the circumflex, the annulus. So here's the risk factors once again for SAM, and here you see that SAM after repair, showing an acceleration of the LVOT flow and a really large mitral regurgitation. And you see without color here that the anterior mitral leaflet is really pushed into the LVOT. Once again, you have here the cutoff points of the anterior and the posterior mitral leaflet length. And then you can use, of course, the mitral multiplanar reformatting based on the 3D to do all the measurements, of course. The circumflex artery, as you see it here on the left side, goes along the mitral annulus. And that is the artery which is distorted or even closed by the surgeon in 2 to 4% of the mitral valve repair or replacement. And it's really very crucial to visualize that before and after. And that is a video which shows it. It's really, look at that video here. It's really from the long axis. It's really very easy. If you go to 110 degrees and then you just turn your probe to the left of the patient and you can follow the course of the mitral. And then based on the 3D, you can measure the distance from the circumflex to the mitral annulus or to the anterior mitral leaflet and height, because that also differs. In most of the patient, the circumflex goes along at the height of the mitral annulus, but in some, the circumflex goes above or even below mitral analysis. And these are very important informations for the cardiac surgeons. So post-repair, what do we have to look for? Localize and quantify, of course, the residual MR, examine for mitral stenosis, and screen for potential complications. So here you see the circumflex just after release of the cross clamp when the left heart is unloaded, and you see that very nicely here. That is the left dominant. The circumflex, that is the LAD, and that is the circumflex. We immediately can tell the surgeon that the circumflex is fine. Then, of course, just before weaning of the bypass, the left ventricle should be de-aired. Otherwise, you will have some problems with the myocardium, which is supported by the right coronary artery, of course. And then the residual MR, which graduation of MR should be accepted. I would say less than moderate is fine. Otherwise, you have to rethink about a second compound. Coaptation length, that was also mentioned. That is the coaptation after repair between the anterior mitral and the posterior mitral leaflet. And you should aim for at least 5 millimeter coaptation lengths after repair. The more, the better. Examine for mitral stenosis, of course. And these are the guidelines you should use valve area, mainly based on 3D and not on 2D, because with 2D, you can underestimate and overestimate it. With MPR, multiplanar reformatting here, you can really exactly know where you measure your mitral valve area. And then, which was also mentioned, the pressure half time and the mean gradient. And if you look for mean gradient, you should assess the heart rate between 60 to 80. And you should avoid mean gradients more than 6 after repair. Otherwise, in the long term, the patient may develop mitral stenosis. So then we scan for complications, and that is one. You see that was a patient with normal LV function before, and you see here really a regional wall motion abnormality. And of course, you look at the circumflex, and if you look at that in echo, you see that circumflex occlusion. Then you scan for this complication, which you have seen before. That is anterior motion to the LVOT with resulting SAM phenomenon and huge mitral regurgitation. And, which was also mentioned by Dr. Patel in his talk, you can damage the surrounding structures. And here you see, that was a case, a robotic case, where the surgeon clips the non-coronary cusp of the aortic valve here, and resulting in a new onset of aortic regurgitation. So you have to check for that as well. So to summarize, the predictors of surgical MVR is surgical expertise, the disease pattern, the patient population, and the correct echocardiographic guidance. So thank you for your attention, and I hope to see you at an online event next year, which we want to host in Leipzig in June 12 to 15. Thank you very much.